Welcome to Profits in Practice. I'm excited to have Lyn Lewars, our guest today. Thank you for joining me.
Oh, glad to be here.
Well, we've shared a little bit with the audience about my background, but maybe share a little bit about how we got connected and how we are working together today.
Sure. So I first met you at Alcon, which was a division of Novartis at the time, headquartered here for the U.S. in Fort Worth. And we were both in finance roles, different parts of the organization, but that's where we first met. And then we both left Alcon, Novartis, and started our own adventures and came together a few years later, December of 2019, at a community event here in Fort Worth and caught up on what we've been doing professionally. And I realized that you were had started your own web CFO fractional firm, and I was consulting with an organization of doctors that was looking for a fractional CFO. So in the first quarter of 2020, we started working together again with the physicians.
Yeah. I remember meeting our first physician and being a little like, what is this organization? And getting connected and just learning a little bit about all the different physicians' backgrounds. Tell us a little bit about the consortium. We refer to it to the consortium or the CIIC. And yeah, we've been working together for about 5 years, going into our 6th year.
Yeah. So the consortium is a group of allergists and immunologists in the United States. We have about 42 practices that are members, and that includes almost 350 physicians and as many clinic locations. And they come together and we help them to negotiate contracts as a group, clinical trials as a group. We seek speaking engagements for them. We have conferences that we bring them together so that they can talk about running their practices, running and looking after their patients.
Moral support sometimes of
Exactly.
This is what's happening in my practice. Is this happening in your practice? Yeah.
Exactly. So, so we have, and this continues to grow. When you and I started with the consortium, they had less than 20 members. So we've more than doubled the size of the group since we started working together.
And one of the things that we do is we negotiate contracts for drugs or services or even, just basic medical supplies. How have you, tell us a little bit about your role and how you're negotiating that and what's important for you to look at those contracts?
So we want to get the optimal contract price and rebate and total discount for the drug or the service that we're working on. Sometimes that requires us to negotiate direct with a manufacturer. And sometimes the manufacturer doesn't want to negotiate direct with an organization like us. They want us to negotiate with a larger wholesaler or distributor. So we have a mix of contracts types that we'll do, but it's wherever we're going to be able to maximize the margin that our practices are going to be able to get on those products or services.
And sometimes what we do is we're surveying our practices that are part of this consortium of what are you using? What do you need? And then we're also going out and looking for those contracts. If you've told us there's a high need for this type of drug, or we think that maybe someone's getting a better price, we'll go to the manufacturer or the distributor and say, okay, what can we do? Or we're bringing more patients, we're bringing more physicians. Do you think it's gotten easier over time? Obviously with 20 clinics and now 40 plus physicians?
Yeah, for sure. I mean, the volume, it's all about how big is your group's volume, gives you negotiating power. A lot of these contracts for the drugs are tiered. So, when we can show that we already start in a tier 3 versus we're a tier 1 volume level, it really gives us strength sitting at that negotiating table. And, when we initially started working with this group, all we were focused on was drugs, but really now we're taking a more holistic look at their P&L and all of their expense categories and saying, here's another big expense category like allergy extracts. Let's work on getting that better. Your insurance is a big cost to your practice. Let's work on that. So when we can combine the needs of 350 physicians and go to the negotiating table, we're in a better position.
Yeah, we're definitely in the continuous maturity of those services and the number of clinics that we're offering. Talk to us a little bit about buy and bill. That's how the organization originally was focused on the RXs and the medical benefits. But how has that changed over time for the organization or even just the industry as a whole?
Sure. So buy and bill is really been in play. Oncology was probably the first group to really move in the direction, because the manufacturers of those drugs were going to allow physicians to buy their drugs, not force them to be sent to a specialty pharmacy. So, but there's a lot of other
Ologies,
ologies.
yeah.
Yeah. So, urology, rheumatology, GI, and obviously allergy and immunology now have programs where they are allowed to buy the drugs and file a medical claim with the insurance company. And so that's the term buy and bill. Buy the drug and bill it to the payer.
I guess from like an accounting perspective, some of the challenges that I see in the clinics are, they're buying the drug. I guess we were talking about an example. They buy the drug on January 1st. Maybe they infuse the patient a few weeks later. Then they don't receive the insurance benefit, the payment for that maybe at 45 to 60, sometimes 90 days.
Mhm.
Sometimes there's a denial, right? And then you have to work through that cash process. And then ultimately you get the rebate. Talk to us a little bit about how, the rebate timing, as well as how do practices know what their margins are on this buy and bill business?
Yeah. So we produce a chart. Drug prices can change every quarter, right? So we produce a chart at the beginning of each quarter where we look at the drugs that we have on our contract, and we say, what's the contract price? What's the prompt pay discount? Do we get a data fee? Is there a rebate involved? So we try to, at the start of the purchase decision, work with our members for them to understand the end-to-end possibilities of discounts they're going to get. And so what they can do is, when they have that patient come in, they see it and they're making the choice of the drug that they're going to buy. They look at, what does the payer allow? What's their, the payer's primary choice of drug? And then they can look at the margin on that drug before they ever order it for the patient. So that helps with the purchase decision. But then the practice systems aren't well equipped to track, when am I going to get that rebate? When
Right.
am I going to get that money from the payer? When am I going to get the data fee from the manufacturer? And so that's certainly the challenge, is, even though we present it in the upfront purchase decision, tracking it in your practice accounting system is not easy.
It is definitely not easy. And sometimes we just have to pull out an Excel spreadsheet and we look at it sometimes by patient or by drug, and we'll say, okay, you purchased it on this date and you paid this much. You had a prompt pay discount, you paid for it. And then we're still waiting on the rebate. We estimate that it's going to be this amount, and we're, waiting for those funds to come in for sure.
For sure. I mean, I think one of the greatest things we've done for some of our members is, when a lot of them came to us, they've had 45, 60-day terms, and we've pushed that out significantly, and that allows for the bumps in the road, like denials.
Yes. Well, and that prompt pay discount really has a value depending on, what the contract is. Sometimes it can be 2 to 4%, and you're expanding your time that you have to pay for that. And from an accounting perspective, cash is king. And I love working with that cash flow. But what I have seen, I'm going to shame physicians a little bit, is they pay with their credit card and then they don't get the prompt pay discount. And I know there's some physician somewhere out there that's living off their American Express points, but we're working so hard for these discounts, and sometimes it kind of gets bamboozled at the end when they go and pay with a credit card.
Yeah, I mean, points are, definitely, there's lots of marketing about the points for
Yes.
that. I think the other thing is they're trying to do some timing of the market, because some drugs, they lock in their price for a year, but some drugs change every quarter. And so, I think sometimes their best intention is they're trying to time the market. I think it also creates for us a huge challenge, because some of our rebate agreements are quarter over quarter growth. So when we have a member that goes and buys this huge quantity and then doesn't buy for 6 to 9 months, it's great for that one quarter that they bought, but they put us in a big challenge for the quarter that follows to meet our max rebate. So that's the impact to us, but which trickles down and impacts all of our members when we're in an aggregate rebate program. But
yeah, well, and it's tricky too, because the physician, or maybe with their accountant, they're trying to do some tax planning at the end of the year. And so then they're like, oh, well, I'll just spend a bunch of money here at the end and I'll take this as inventory. And the problem with buying months and months in advance is you have 90 days, even with our 90 days to pay, you may not use enough of that inventory in 90 days, but you have to go ahead and pay for it. So one of the first things we work with private medical practices is helping them move to accrual accounting so that they're matching what, the date of service that they're seeing someone, and then they're recognizing that revenue in their accounting system. This doesn't mean for tax purposes, but literally helping them match up that income and the expense in the same time period. And sometimes they're making a lot more money than they thought they were. And sometimes it's like, oh, that's more painful than that's not as big a benefit as I thought. And then layering in the rebates on top of that, which we know will come later in the practice.
Yeah. And it takes space to just house all of these drugs in your facility, and they're very expensive, and hopefully we don't break a vial.
Don't break a vial, don't have theft. I don't think there's like a high theft rate. But we do hear from a lot of physicians about prior auths and denials and things like that. And all of that impacts their cash flow. And so getting the practice just to be almost a well-oiled machine and like, this is our buy and bill process. Sometimes it's hard with those fluctuations in pricing.
Yeah. I think for most practices, inventory management is a visual thing, not a calculated.
Yeah, so I wish everybody had barcodes and, a very accountant-ish type of process. So what, I guess why is it so hard? Why can't the physicians do this kind of tracking of these rebates and everything in their EMR?
Well, I don't think the functionality has been built out in the EMR. And then there's also just, there's EMR for scheduling patients and clinic notes. And then there's other add-ons and bolt-ons depending on the EMR your practice chooses for the billing and the inventory management, and your purchasing happens outside of your EMR. So I think it's your collective technology landscape. They're not all connected, and integrated, and so it becomes a bit of a challenge to track the purchase from start to finish.
Sure. And when we're pulling together a set of financial statements, we are having to go out to the EMR or their inventory tracking, and we're pulling in all of these different components to create a complete set of financial statements. And of course, none of them talk to each other. Some of them allow you to download in a CSV or Excel. I mean, it's a data mismatch of, what's happening.
And I think in the practices, not all of them, we have a lot of single doctor or single locations, right? Not all of them have a sophisticated finance and accounting person in them. And so sometimes when we go and have that conversation with them, it's a new lingo.
Yeah. Yes, definitely. I guess if you were meeting a new physician that was, looking to explore into buy and bill, what kind of advice would you give them?
We try winners only is we help you understand which products and therapies you can buy profitably. And so we don't want you to make a mistake of buying a drug that you're going to be underwater on. So we do a buy and bill university for practices that are new to this, where we talk about how do I find out what my reimbursement's going to be from the payer? How do I understand my drug price? How do I understand my drug rebate? How do I understand whether I have to get a prior authorization or not? Which payers are have better margins on these therapies, because it's not across the board that every payer is the same. Even within large national payers, they have regional price reimbursement differences. So we really want to make sure that practice understands how they pick the winners only.
Yeah. Well, and what are their choices if it's not a winner? Right. So it's not that the patient doesn't get served. They're just going to get served differently. They're not going to be under buy and bill.
Right. So there's still, once the decision of the therapy is made, and there's still an effort by the practice to get what's called a prior authorization. So they have to connect with the payer to get authorized to give that therapy to the physician. And then if they're not going to buy and bill the drug for a variety of reasons, because it could be a not profitable buy and bill. It could be that the payer mandates that it has to go to a specialty pharmacy and be a pharmacy claim. So the way that a patient would get that drug, if the practice can't buy and bill is they would send it to a specialty pharmacy, the ones you're familiar with, right?
Yep.
The CVS, the Walmarts, the Express Scripts. So, but our preference is we want to be able to buy and bill these, therapies.
Let's talk a little bit about the billing component. What do you see working for practices? I've seen, they have a great biller in-house and they have one person doing it. And I'm like, okay, that person's great, but it's a single point of failure if such and such doesn't show up that day. We've had some who do third-party billing. That can be kind of hit or miss. And then we have some that kind of have maybe a mix. The infusion piece is third-party billing and everything else is in-house. What have you seen?
Definitely all of those mixes. I think what happens is people get asked to wear a lot of hats in one role. And then their bandwidth gets consumed, I think is another challenge. So where you can, billing is so critical because it's your cash flow.
Yeah.
So I think where you can, I would try and make sure that person isn't overwhelmed with responsibilities because it's so crucial that you get your billing and your cash flow right. I think the challenges with the billing is actually the reporting and where they get to see, what claims have been paid and haven't paid, where, how they manage their denials. Because, there's a constant new volume of claims they're working to bill, but you can't forget about the ones that are hanging out there, and especially the ones that have been denied because they have a time limit on them.
Yeah.
And, we've heard some
terrible stories.
Some terrible stories from our members of, claims that went unpaid, and they had no idea. And these drugs are very expensive. And so mistakes like that can really, crush a practice's
They can
cash
crush
flow.
Sure. They can crush a practice and it can wipe out your profit for that month or those that set of infusion patients for sure.
Yeah.
And I do think one of the things talking about wearing multiple hats, I think practice managers and billing and non-clinical staff in medical practices are stretched thin. Like they're doing a little bit of everything. And a lot of times they're not specifically trained for that. What we see is the practice manager normally becomes the accountant. And I'm like, okay, like maybe you had a good skill set at this, but you're not necessarily into debits and credits like me. Like, and they're like, okay, well, show us a few tricks or, we become their accounting department and help. And they're like, most of the time they're just like, oh, thank you for taking this over. And we're meeting with them. But I do think there's lots of opportunity to learn, but there are a lot of stretched roles for sure.
For sure. My background's in shared services. I think that if you're not going to commit to have that expertise in your practice, I think there are a lot of third-party companies out there like you and like billing companies and that can really help your practice until you're ready to take it back in-house.
Yeah, that's what I was telling someone last week. I was like, this is not a marriage. Like, we don't have to be together forever. Our team can help you get set up and get organized, and maybe we help you for a year or two, but we also can call a timeout and say, we think you're ready for a full-time person. And this is the reason why. I definitely know from I have fatalist thinking. I think that sometimes I make a decision and that has to be the decision forever. And maybe as I've matured, I'm like, okay, I can pivot. I can try something else. I would say our physicians in the consortium are very much like that. It's a very entrepreneurial group of people.
Oh, for sure.
Or, being part of really large practices.
The days of just being a physician only and seeing patients and surviving as a practice are gone. So, I think you have to have physicians that are thinking about different ways to evolve their practice.
Yeah. And a lot of our physicians are exploring multiple types of revenue streams, right? Research or, through legal entity structures, I see they're going to become landlords, right? They may own a building and then their practice is using part of it. And another ology, who's a great referral source, could be the other lessee. So I do think there's, a constant, how can you make the practice better, more efficient, but also what else is out there that you should be looking at?
For sure.
Well, is there anything else you think we should tell physicians? I'm trying to what else would we tell a physician for buy and bill?
Maybe did we touch on GPOs and how they make money and how you need to make sure you get your part of that?
Yeah. So we've talked about how the consortium is a GPO. We call it a GPO plus because we think we're a lot more than that. But yeah, tell us a little bit more about how GPOs, how they make money.
Okay. So a group purchasing organization makes money by the manufacturers pay them a GPO fee based on the volume of drugs that their members buy. And then also there are wholesalers and distributors that will pay fees based on connecting members with the wholesaler and distributor community. So sometimes those are called a channel partner, but those are the two flows of fees, as from manufacturers and then from the wholesaler distribution group. And it's common that you can negotiate an agreement where your GPO would get a share of those fees from the manufacturers and the wholesalers and distributors. And so what I guess I would stress is you need to read your agreement from end to end.
Yeah.
You need to make sure that in those agreements, your purchase volume and data is private and not being resold, and that there are parts of the fees that they are sharing with you.
Yeah.
I think the other thing is you need to understand which GPOs you're aligned with. We often find our members are like, I had no idea I was signed up with that GPO, and they've been making money off me for years.
Or they didn't share any of those fees. Can I go? And we're like, yes, just ask. If you ask, they're required to disclose. I don't know why they don't have to disclose it to begin with, but once you ask, they definitely have to disclose it.
Yeah. I mean, that was one of the agreements we looked at when we started with the consortium. It was like, oh, we're entitled to annual reporting about this. And and then
it was a significant amount of money.
It was. And open payments reporting is another way you can see, how much in fees the GPOs you're associated with are getting from manufacturers. So there is public reporting, and then they are required to share that reporting with you. But you probably see this more than me on a variety of things, is people aren't reading their agreements in full detail.
People are not reading their agreements in full detail. I think in another episode, we're going to talk about fraud, but it's also for physicians, it's the personal guarantees on some of these things. And so we'll talk a little bit more about that in detail. But yeah, I know it's a very busy world. These contracts are not 2 pages. These are like 20 pages, and they're written by attorneys. But it's definitely worth the time to go through it, or, hire legal counsel who's familiar with these types of contracts to go through them. I think it's also funny-ish that you have to remind the GPOs sometimes to pay you. Or we have to remind the manufacturers and distributors, like, oh, by the way, you owe us money. And so if, a clinic wasn't part of a GPO, I mean, we're knocking on their door every day.
Yeah.
But the clinics, they don't have time for that. Or, maybe their practice manager or whoever's working with their accounting may not fully understand that contract. If it's not in front of your face every day, like a patient bill, you may forget that someone owes you that money.
Oh, for sure. I think there's a lot of money left on the table by practices for not being able to track well their purchases and demand the rebate they're due.
Yeah, absolutely. Well, I think this is a good stopping point. Thank you for sharing with us. I've obviously enjoyed working with you, and I think we have a great group of doctors that we enjoy working with. I'm always intrigued by what they come up with, like entrepreneurial wise, and then Lyn and I kind of have to sometimes operationalize it, but it's always fun. It's exploring great ways for the physicians to remain profitable, remain independent. If there is no profit, there is no serving the patient. And so that's really our focus in helping these practices be and remain independent. Lyn, thanks for joining me today. If someone wants to reach out and connect with you, what's the best way?
Sure. I'm on LinkedIn, so you can find me there and ping me there. We also have a CIIC website, CIICclinics.org, and you can do the contact us, and happy to get back with you. Whether you're a practice or a vendor or a supplier, we're always looking for new opportunities for our members.
Yep. And we'll be sure to put all those links in the show notes to make it really easy for everybody.
Great. Thanks.
Thanks for joining us. Thanks for joining me on Profits in Practice. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with a fellow physician. Your financial wellness is just as important as your patient's health, and we're here to help you thrive. Connect with us via our website at webcfo.com. Thanks for joining us.